Okay, so I'm Dr. Abdelhak, and this is the first sentence of the first podcast
of many to come.
I am a maternal fetal medicine specialist, which is a high-risk OB, and Kristin, my partner, is a midwife with 20 years experience as a certified nurse midwife.
This one we're going to talk about induction, because a lot of women hate it.
We're going to shed light on induction, and we're going to talk about why it's not the boogie monster and why it might be your friend.
And it can actually be a great tool when used appropriately, like most tools.
Correct. And we know that anybody who tunes into a second podcast was not scared off by the very scary thought of midwife and recommending induction.
Being induction happy.
Right. But we're going to explain ourselves because we are, at a minimum, very pro vaginal birth. We try to find alternatives to C-section. And then we embrace C-section when that's necessary also. But when we talk about induction, it's not because it's something that we feel is beneficial to the provider, or it's something that we think can actually be beneficial to the patient. And we're going to spend a little time talking about why that is.
Let's get into it.
Induction of labor, friend or foe?
Yeah, I mean, I think it gets a really bad rap for no reason.
Well, no, not for no reason. There is some downside, but yes, it does get a really bad rap.
Yeah, I guess not for no reason. But I think there are people who are using it inappropriately, and maybe that's why it gets a bad rap.
Let's start with that. I would say, I'm not positive because I haven't done this in a while, but I would say if you Googled, how do I avoid a C-section? If you put that into Google or any search engine, I think that the number one answer that you're going to get, or source, is going to be repeatedly, don't let them induce you.
Because that was kind of a big thing about 10 years ago before the research kind of caught up with that induction is a good idea.
Oh, you're skipping to the end of the movie.
Well, I don't like the boring parts. The middle's the boring part. Let's just get to the guts of it.
Do we have a whole plot? There's character development, there's storyline. You're just going straight to the end.
I don't have time for that.
So we're going to talk about, does induction increase the C-section rate? And I think that is a question that has a different answer today than it did even 10 years ago or 12 years ago. Now, I will tell you that I have been inducing patients for 20 years. And when Kristin joined my practice 15 years ago, she was horrified, as she recently told me. Horrified, was it?
I think the word was horrified, shocked.
Shocked.
I kind of just like gritted my teeth and I was like, okay, this is what we're doing. You know, like that feeling when you get on a roller coaster and you're like, oh, okay, I'm on it. And like, I don't really have a choice. I just got to ride it to the end.
So Kristin is saying for a paycheck, she's willing to look the other way, even if it violates every medical ethic she knows.
I was more like, let me give this concept I was young still. I only had been working for 5 years and I had only worked in one practice for 5 years. So I was like, There must be a reason why this guy is doing. When I met you, I liked you. You had a very warm, wonderful personality. Like there's something about you that you can trust. I think I can read people well. And I thought I was reading you appropriately. Back then, I think I read you well. And so I was like, I mean, this guy seems crazy to me, but there must be some method to this madness. And I was right.
Yes.
So good for me.
Glad. I didn't realize that you had seen it that way. To me, it was obvious the way to go. Not, it was obvious that it was the right way to go medically. And you had a good poker face. You never said, are you nuts? What are you talking about?
Well, when you go to midwifery school, first of all, there's a lot wrong with midwifery school in general. I mean, there's a lot they don't teach us. I think there's a lot that midwives could teach doctors and doctors could teach midwives in general. But they make it this very, induction is the devil. Well, induction is the devil.
They do, yes.
Oh, yeah. So coming from school and then going to a practice that was very midwifery focused.
Let's back it up another few steps. Why was I inducing patients?
This was in 2010. So this was...
When you joined me?
Yeah, this was like...
So let's go back to 2000. Okay, so in 1997, I graduated my residency in obstetrics and I started a fellowship at NYU in maternal fetal medicine, which is the subspecialty of OB that concerns itself with high-risk pregnancies and complicated diseases, women who have medical problems, who have bad outcomes, and a lot of ultrasound and diagnosing fetal anatomical issues. After graduating from NYU, I decided to go into private practice. Well, not immediately. I had to first establish myself somewhere. So I took a job at Hackensack in New Jersey, being the maternal fetal medicine guy, covering the ultrasound unit, teaching residents, doing what most academic maternal fetal medicine doctors do, teaching, supervising, reading ultrasounds, counseling patients, not having my own patients, but then over a short amount of time, I started building a little practice, which turned out to be heavily Orthodox Jewish, maybe because I aimed it at that direction.
Well, that was your community, and then you were able to reach out to people that you knew in that community?
Yes, I actually had a familiarity being Orthodox, and I did my residency in Maimonides, which was a highly Orthodox neighborhood.
Right,
Kristin
I also did my training there, and I am not Jewish.
And
nor Orthodox Jewish.
Neither one, are you sure? No. I ended up with a very large patient population that was Orthodox. And that is very important because these are women that are designing, they're planning on having 8, 10, 12 children. I mean, we've had patients who had 19 or 20 children. And to do that, it's really important you avoid C-sections.
I think one thing that I noticed about working with Orthodox Jewish women that I didn't notice when I worked with non-Orthodox Jewish women is that they will bend over backwards and do anything to be with the best doctor.
Oh, yeah, they go out of their way.
They will travel, they will...
Right. They're focused on good healthcare.
Yes.
And also there's no advertising.
Right, it's all word of mouth. I mean, there is, but it's just word of mouth.
You can't buy... you cannot buy that.
No, because it's like their sister, their cousin, who they know.
Either their sister is happy with you,
right.
or So
I mean, more than any community I think I've ever worked with in my whole career, they will seek out research and go for the best.
So when I had that community, and I was pretty much groomed to take care of them because my whole religious background, my training at Maimonides, which was a low C-section labor and delivery, my training at Elmhurst, which was a high forceps hospital, a lot of forceps deliveries, and then being a high-risk MFM, it really fit perfectly to take care of women that didn't want C-sections. And so that's how I established myself in that area. And then eventually, after 2 years working in the academic part of the hospital, with the hospital's blessing, I went private, which just meant that I worked part-time for the hospital because they asked me to stick around and help out. And the other 4 days a week, I delivered my own patients from A to Z, which is unusual for maternal fetal medicine doctors. They
just consult mainly and do ultrasounds. I mean, do you know any other MFMs that deliver?
Yeah, so the Dr. Antoine in New York, and Dr. Baxi.
Are they MFMs?
Yeah, they're sure.
Baxi's an MFM?
Absolutely.
Yeah, so it's not so common. I mean, I didn't really hear of it when I was going through my training.
Where am I up to? Okay, so it's like 2002. I opened my own practice. I'm finding myself with more and more Orthodox women whose number one concern is avoiding a C-section. A lot of that is VBAC, twin deliveries, breech virgins. Then, of course, there was cerclages, preterm labors, diabetes, all the other things that come along with high risk. But I was having a lot of patients coming to me seeking options to avoid a C-section.
And then that's what led you to the induction. So how did you make that?
Over time, and I can't say that there was an epiphany one night. There's nothing like Mormonism where somebody came to me and showed me the golden book. Yeah, that would be really cool. By the way,
the Angel Moroni.
Right. It was more like over time. It was kind of my own understanding of what the problem was, and the problem became clearer and clearer to me that babies are really big today. I say today because they've gotten bigger over time, and that if you labor quickly and deliver quickly, you have a much better chance of avoiding a C-section. Meaning women that labor and progress through labor nicely are going to have a normal delivery, and the women that don't labor and progress are going to end up with fetal heart rate decelerations and other issues, and then getting stuck, and then they need a C-section.
I think that was a major injustice that I noticed with women that in New York City, where I started in Brooklyn, women are older. The average age of a woman giving birth in a major metropolitan area is 31 years old. And they were comparing themselves to the Ina May. Ina May is like a very famous midwife in her farm in Tennessee, where the average age of patients is 21. And Ina May started her practice in the 70s, where the average age was 21. So it's hard to compare a 31-year-old laboring woman to a 21-year-old laboring woman. And they would expect to be compared similarly, but I think they gave themselves an unfair expectation about what reality was going to happen in their birth.
I think that's a really good topic, and it's a really good podcast, pregnancy in the women over 35, because it's shocking how statistically their section rate is 2 times normal, over 40 at 3 times average. all complications are elevated, and we should actually remember to do a podcast on
so coming soon. But there's a lot of things to do to overcome it. I don't want to sound like a negative Nelly or a pessimistic Mary, but
we're getting off our storyline. We're
about why you
have
decided.
a plot here.
Yes, the inductions.
It's just getting juicy. Now
I gave the ending away. Everyone knows what's going to happen.
I've got a lot of patients that want C-sections, and I'm just developing my my strategy. So it occurred to me, and it was kind of obvious, that I want women to have quick labors. I mean, it almost sounds silly because, what else would you want? But, that is a part of the logic, because that leads you, once you realize having a quick labor is the key to avoiding a C-section.
So let's elaborate on that a little bit. So having a quick labor is key because, one, every contraction less that you have in your labor is less chance for fetal distress.
More than that, as the contractions add up, the chance of fetal distress
goes higher, right? So like it's stressing the baby out, it's stressing the uterus out as your labor is longer.
Explain to the audience why contractions are stressful to babies. They can handle it for the most part, and they're designed to handle it, but what's stressful about a contraction?
When the uterus contracts, it constricts the flow of blood flow to the placenta temporarily, and most babies can handle that temporary constriction of blood flow.
So that's why contractions come in intervals, because you have a contraction and then there's 2 minutes or so where the baby's getting good blood flow, and then there's another contraction.
Right. It's like running intervals on a treadmill.
It's like you're holding your breath for a few seconds. Anybody can hold their breath for a few seconds, but
doing it over and over again.
Right. And then over time, though, it becomes harder, and especially if you're getting stressed, then it. So yes, there's 2 problems with long labors. Long labor by itself means that things aren't going well, because if they were going well, you'd have delivered already, obviously. And then the other problem is that a long labor actually, eventually, the baby says, hey, I really don't like him here anymore, and I'm not getting enough oxygen, and get me out.
Or the uterus says, hey, I don't have any more power anymore. I'm losing my power, and the contractions aren't as effective.
Granted. Again, I know I'm not sounding like a genius yet, because so far all I figured out is if you have a quick labor, you're going to avoid a C-section. But then the next step is, okay, so now how do I, what's the right word?
Mimic normal labor. Because really what you're trying to do is you're trying to go back to a 21-year-old having a natural labor.
No, that's not happening.
Pitocin is meant to mimic a normal labor, or an induction is meant to mimic a normal labor.
I am trying to manipulate the process by giving women having quicker labors, and I realized that to have a quicker labor, you have to have a smaller baby.
Right, but also having a quicker labor is the way nature intended it to be. That is back to nature.
Well, we're getting there. Again, you keep running,
I know.
I'm not going to sell any books like this. So, quick labor is better because you avoid stressing the baby and things fit better. And having a quick labor is done by having a smaller baby. Again, would be great if babies are ordered on Amazon and you can check off the small baby box.
6.5 pounds,
right? So
please.
How do you have a small baby? Now, this is where it gets interesting. You have a small baby by realizing what makes babies fat. And what makes babies fat? Sugar. Just like what makes all of us fat. It's donuts and ice cream and cookies and candies.
Carbohydrates.
Right. So let's just think about the physiology. Why does somebody get fat when they drink soda and eat cake and donuts all day?
I mean, you're talking about like insulin response, and
I'm talking about just simple energy storage, right? You fill your body up with sugar.
Right. It's like a body in, body out. It's like fat goes in the cell, and if not enough fat goes out of the cell, then you have this fat cell expand, and you get fatter.
So you can think of fat cells as just energy storage.
Right.
Sugar storage. If you eat too much sugar, your body says, oh, good, extra sugar. We should store that. Maybe later we'll be hungry, right? Or maybe later there'll be a famine. We should put this away.
Right.
So the philosophy of avoiding C-sections is about of having nice, quickly progressing labors. And quickly progressing labors is accomplished through having babies that fit. You can't really change the maternal pelvis so much, so you can manipulate the size of the baby. So then it's about having babies that are smaller. Again, easier said than done. How do you have babies that are smaller? You restrict your carbs and you exercise, because both of them lead to smaller babies.
Right, because if you gain an excessive amount of weight, your baby is going to gain an excessive amount of weight.
Why is that? So we talk about the body's designed to not waste energy.
Right.
If you consume more energy than you need, your body will convert it into fat.
Right. And then your body very smartly, because we've only really lived in a world where we have too much food in the last 100 years, or maybe even less, your body very smartly has the sensitivity to less sensitivity to insulin, especially in your second trimester and third trimester. So it's like you're eating the same, but you're gaining more weight anyway. You're not changing anything about your diet, but your body's less sensitive to insulin. And so you're gaining more weight.
Not following that. Why would you gain more weight? Because you're not peeing the sugar out. Insulin pulls the sugar out of your blood into your cells,
right,
where
so
it's going to be used.
Right, but you're less sensitive to insulin. So when you're less sensitive to insulin, isn't working as well as a lock and key mechanism, and you have more free floating glucose in your body.
And what happened to that sugar?
That sugar is then staying in your body longer and then getting stored into your cells as glycogen, which you don't need insulin for. And then also as subcutaneous fat.
Yeah, so I'm not sure if I agree with the soundness of that. I think that if you have high blood sugars, you're not efficient. Efficiency is not losing energy; it's storing it. Either using it or storing it. And being diabetic is being non-efficient and having high blood sugars that eventually will escape.
Right, but it's like
urine.
a catch-22. So you release more. Your glucose levels are higher because you're less sensitive to insulin, and then your pancreas produces more insulin as a result of these higher glucose levels, and then it's like this never-ending.
So you're compensating, and the compensation is going to eventually lead to storing too much fat.
Exactly, which is why diabetic women tend to gain more weight, and they tend to have bigger babies, both, because the babies are gaining an excessive amount of weight.
Well, I think gaining weight leads to diabetes. I'm not sure if it works the other way also.
Part of the problem of why women are more prone to be diabetic when they're 30 years old and pregnant is because of insulin sensitivity, that it decreases when you get into the second and third trimester. That's why we test for...
All right, we're going to label that as insulin sensitivity.
I actually have a theory. Another theory is total side note, that what we really should be doing is testing women's insulin level in addition to their glucose when they do their 3-hour glucose or their regular glucose test. And we will find that they are extremely hyperinsulinemic, the ones who eventually become diabetic.
I think that we could marker for diabetes.
I think that we could pick up gestational diabetes earlier with insulin testing versus glucose testing.
That'd be cool. Maybe we should look into see if anybody's looked into that. Maybe have you ever researched it to see if somebody's tested that?
They're just scratching the surface now of insulin for regular diabetics, of like what insulin means.
Back,
type 2.
I want to lose my. Oh yeah. So how do we get a smaller baby? So so if you eat ice cream and you're pregnant, what's happening is your blood sugar is going to go up. Your body's going to recognize that there's more sugar, or more energy, more carbs
more
than it
glucose.
needs, and it's going to turn it into fats for storage. The property of glucose, as opposed to fats and proteins, is that it can cross the placental barrier passively. It does not need to actively be transported. That means that whatever blood sugar you see, the baby sees, because that automatic, like the levels will rise equally.
It's just direct, right?
And the baby does exactly the same thing the mother's going to do. It's going to recognize that there's extra energy storage, energy. It doesn't need it, so it's going to turn it into storage. So the baby's going to get fat. And fat babies are a problem. They make for cute pictures, but they are a problem because they have to fit. So I want my patients to not, to be very carb restricted. And I want them to exercise, because when you exercise, not only are you burning carbs, but more importantly, you are kind of oiling the machine so that your metabolism is running better all day, and you're burning carbs better all day, and you're not turning it into, your blood sugar is running lower, and your baby's not going to end up with extra carbs to turn it into fat. Now, the argument somebody might make, you should make it, well, 1 second, isn't that unhealthy, limiting yourself or dieting when you're pregnant, right? You should say it so it's official.
Okay. Oh, wait a minute. Isn't it that you should be eating for 2?
No, you should not be eating for 2. So the real phenomena is that today we are eating way too many carbs. Sugar is ubiquitous, and it is cheap, and nature does not account for us eating sugar all day.
It's readily available everywhere.
Right. And people are so much heavier, and there's an obesity epidemic, and we're eating, and babies are way bigger. So in actuality, what I advocate is that you go back to what nature intends, which is a very limited amount of carbs and a much higher protein and fat diet and a much healthier pregnancy.
Right. Also with periods of fasting, because women are not exempt from this obesity epidemic, just like children aren't exempt, right? So we have the children obesity epidemic.
And I think diabetes actually is a very good model, because diabetes is extreme, right? What happens if a woman's diabetic? She has elevated blood sugars, and the baby has elevated blood sugars. The baby, unlike the mom, is able to use that sugar easily. It can store it and it can use it. So the baby takes that blood sugar and converts it into fat. Whenever you have a very large baby, medically or from a maternal fetal medicine point of view, you always have to say, was the mom diabetic? Why is this baby 9.5, 10, or 10.5 pounds? Was the mother diabetic? And we actually do know with scientific certainty that if you have a large baby, you're more likely to have a cesarean delivery.
So the babies are bigger, and so the women, to combat that, one of the things they can do, and induction is another one, which we'll get to. I know I keep jumping ahead, but they can exercise when you exercise, you utilize that glucose that's free floating in your system and in your blood, and they can eat less carbs.
Correct. So that's it. That's the idea. The idea is, let's go back to nature. Nature says that, babies should fit, but that means you have to live in a natural environment. And living in a natural environment is not one that's consumption of a large amount of processed food, sugars, carbs, soda, cookies, all the good stuff. All the good stuff is unnatural, and it's what's making babies too fat, too large, and increasing the C-section rate.
Yeah, and I want to say two things about that. One is, personally, this is my belief, and I don't think we've ever talked about it, and maybe you'll agree or you'll disagree, but I don't think the first trimester matters as much. I don't think that if a woman gains a lot of weight in the first trimester, because a lot of women have a really hard time with the first trimester because they're nauseous and they want to eat carbs all day long. So I think women should give themselves a little bit of a break in the first trimester. And then when they get in the second trimester, past 13 weeks, they should really focus on this low carb exercise regimen. And I want to add one thing to that, which I think is fasting. It's not good to just be on a constant glucose drip all day long. You get up and you have a snack. 2 hours later, you have a snack. You have another snack. And then you go to bed at 11 o'clock and you're having a snack, because that is just a constant access to glucose constantly all day long, which leads to a constant access to insulin all day long, which is then just going to make you fat. So that's why I say that the fasting, the concept of timed eating, where you kind of stop eating 3 hours before you go to sleep, or 2 hours.
Regimented.
Exactly. So you're not just eating willy-nilly all day long. That's another
So I
layer
couldn't agree
to that.
more about the first trimester, and even through this most of the second trimester. So yes, I don't advocate for any type of dietary restrictions the whole first half of the pregnancy. Like you said.
So you're saying up to 20 weeks.
Up to
even.
20 weeks, right? Because the first trimester, most women are just trying to keep food down or dealing with nausea. And
right, like 80% of women are.
If you look at big babies, they're not big at 20 weeks.
Right, because every baby is the exact, which is why we use 8 weeks to measure when the due date is because all babies are the same size at 8 weeks. And then when you get past the embryonic...
So that individuality, you don't see, I mean, it progresses throughout the pregnancy. At 7 weeks, everybody's exactly 1 centimeter. At 10 weeks, we're all 3 centimeters, from top to bottom. And at 20 weeks, we're very similar. Linebackers on the New York Giants and ballerinas on our Broadway. I don't know where ballerinas are.
Carnegie Hall? I don't know.
Yeah, no. Where's the other place?
The Met?
The Met, yes. At 20 weeks, they are the same size. And pretty sure at birth,
maybe gymnasts is better.
Linebackers
because ballerinas can be tall. Maybe gymnasts is a better.
Because ballerinas are actually adults, and gymnasts are like 14 or something.
Well, gymnasts are usually like under 5 feet. Successful ones.
They are?
Yeah, they're small.
Yeah, but I mean, you get your gold medal when you're 16 and you're done with that.
Yeah. Or maybe 20.
I'm sticking with ballerinas for this analogy.
Okay.
So up to 20 weeks, growth of a baby is not really environmental. It's more programmed. That's just the way it goes automatically. We're all going to get to the same place. And I don't believe that diet has a major impact. I don't think babies get fatter and are set up to be bigger in the second half of pregnancy. I think at 20 weeks, if you start watching your carb intake, I think you can control the situation. So the idea here of the nature back method, the one is that the baby shouldn't be too big. Now, that's only one way to manipulate the size of the baby.
Right, to not have a big baby. The other way is to
induce. Because babies will continue to grow, right? Babies don't get to a predetermined weight. They just grow and grow and grow until they deliver, right? And if you have a preterm baby, you have a small baby, they're smaller. And if you go overdue, the baby's going to be bigger.
Right. And on average, I mean, they're growing exponentially towards the end of the pregnancy. So they're growing half a pound a week when you get to the end of the pregnancy, on average.
That's an extreme, but yes, they can. At the extreme, they can grow a half pound a week.
So if you deliver at 39 weeks with a 7-pound baby, you could be looking at a 7.5 pound.
Yes, that's the idea, right? So you want to deliver a average sized baby or even a below average sized baby. And to do that, you need to get the baby on the way out before it gets too big.
Right. And an average sized baby in the U.S. is 7.5 pounds.
What do you think the average sized baby was 100 years ago? 1920.
Well, I think I know the answer, but if I had to guess, I would say less.
It was significantly less. It was 1 pound and 6 ounces less. And that is huge different. So the baby 100 years ago was average size was 6 pounds, and now it's 7.6.
Right.
And you should argue, well, people are healthier and moms are bigger, and people are living longer, and they are, yes, but not 20% bigger.
Right. And also we know that obesity is a huge problem.
We do.
And I think I read a study somewhere that the average size of a baby in Europe is actually 7 pounds, but in America it's 7.5.
So I have a patient, and she's very interested in avoiding a C-section. Let's say she already had one. And the reason she had a C-section was because she pushed her 8.5 pound baby for 3+ hours and it wouldn't come down. And then she was told, sorry, but this baby's not coming down. We have to do a C-section.
Right. We tried, but now you're having a C-section.
Now she comes to me and I really don't want a C-section. So I'm going to counsel her. And I'm going to tell her, A, you are going to watch your carbs from 20 weeks. B, you're going to get exercise every day. And exercise does not mean, Ironman marathon. It means 30 minutes of vigorous walking. When you are pregnant and you do 30 minutes of vigorous walking, you are breathing hard and your heart is racing.
Yeah. So when I talk to women, I usually use something a little bit more specific. And I think some women are familiar with the concept of zone 1, zone 2, zone 3, zone 4 exercise. That's kind of a...
Well, that's good because I have no idea.
Exactly. So for the women who are familiar with that, it's usually zone 2 or zone 3. Walking usually isn't enough because women will say, well, I walk for my commute, and in New York City, everybody does commute. I mean, before COVID, they commuted. And I don't think that they're getting their heart rates enough. It's like what you said, they have to be perspiring a little bit and they have to be out of breath a little bit.
Right. So what zone do you tell them to be
Usually
in?
2 or 3. And then once you kind of get past zone...
If you are walking in zone 3, do you get a ticket going below the speed limit? How does that work?
Like a cop on a bike is going to pull you over?
I don't know. Are these zones actually
like a mall
somewhere?
cop?
Okay, I am not going to endorse this zone 1, 2, 3, 4 thing, but okay.
5. There's 5 zones.
5 zones. Okay.
But it's all about lactic acid buildup. So once you start producing lactic acid, when you get about 2 milliliters of mole of lactic acid production in your exercise, you're turning over from an aerobic exercise where you're utilizing oxygen to an anaerobic exercise. So I tell women they have to be an aerobic, not subaerobic, which is walking, and not anaerobic, which is like a HIIT and kickboxing and, spinning your brains out.
A healthy level of exercise, so they're not producing acid.
Right, not too much.
Although
anaerobic
metabolism is a lot less efficient, and you burn a lot more fat, by the way. I think that's less healthy.
In aerobic, you burn more fat. In anaerobic, you're using glycogen. Your liver is either making it or you're getting it from your muscles.
Okay, I'm not going to argue with this because I skipped all the nutrition classes when I was in medical school. Let's get back to induction because that's really what we're trying to get to. Now, if a patient gets to the end of their pregnancy and the baby is big, okay, there's a window. There's like a window of opportunity. I get her in labor, or she ends up with a C-section because the baby gets too big for her to get out. So I'm going to advocate inducing. And then you should say, 1 second, oh my gosh, can you induce a VBAC?
Oh my gosh, can you induce a VBAC? I'm so nervous.
Of course, all those people that told you can't induce a VBAC were lying. I shouldn't call them lying because I know a lot of them were...
bending the truth.
Not being fully honest with you. You could totally induce a VBAC.
So how can you induce a VBAC? What methods are available to you?
Totally different podcast because that's a whole conversation. But
about how to induce the VBAC.
You can give them Pitocin, and
break the water.
And you can use mechanical dilation for the cervix, break the water, give them Pitocin. But the point is, I induce my VBACs and my primary Paris patients who are on, having a first baby that's big. And Kristin walked into this practice where the high-risk doctor was inducing VBACs.
Yeah, so that, for me, that was like one of those moments in my life where I have to look back on it and be like, there's always humility. There's always something new to learn. You go to school, you learn this one way, you're told that VBACs have to go into labor on their own. And then the very first month that I was with you and you just VBAC after VBAC after VBAC was successful. And I just eventually, it only took a month or 2, I was like, I was wrong.
Started drinking the Kool-Aid. Great. So the reason why I'm an advocate of inducing my VBACs is because I don't want the baby to get any bigger, and I feel it's safe to induce a VBAC. And it is extremely difficult for the provider, meaning it is time, not sensitive, what's the word? Time?
Intensive.
It is time intensive, right? I might have to spend 12, 18, I one time spent 36 hours in the hospital with one VBAC trying to get her delivered.
Right, because you have to make yourself readily available in case, God forbid, there's a problem.
Correct. Almost every hospital will have some kind of rule that says if you're inducing a VBAC, the attending physician should be in-house in case there's a problem.
Right. And one of the things that we kind of talked about like a couple years ago was that even when we are inducing a VBAC, and God forbid we run into problems, the mom and the baby are fine.
Correct. That's why we're in a hospital. That's why we're not VBACing people at home. So yes, let's say 99% of the time, there's not going to be any uterine rupture, regardless if it's a successful VBAC or not. But 1% of the time, you get into a situation where the uterus is opening up. And A, we're on top of that. So we hopefully recognize it before it gets to the point where everybody's in big trouble. And B, we are down the hall from the operating room.
Right. And I mean, the safety of VBACs is another episode entirely. But one thing I want to say just here to kind of remind everyone is that women kind of, I think, envision when a uterus ruptures, it's like a balloon popping. They're like, oh my gosh, this balloon's going to pop and my baby, we're dead. But really, it's like a paper tearing very slowly. It's like when you rip a seam. It's a much slower process. Yeah. Although, at some point you can get a real rupture and the whole thing can open up. Because we've seen babies in the abdomen before. And after, I want to point out, because before I scare anybody off the podcast, how many thousands of VBACs have we done? And well, we're doing like over 150 a year, right? 200 a year.
And we've had, I don't know, dozens of different levels of uterine rupture. And every one of those moms
was fine.
It's okay, yeah.
And their baby was fine.
Baby was fine, right. And sometimes uteruses have been lost, but we didn't lose a baby or hurt a baby with a VBAC. So it's not like we're doing anything that is dangerous. We feel pretty safe because we feel like we can act if something bad happens. But we're way off topic. Why induce a VBAC? Okay, so now this is the problem and that I encountered for years. After developing this, philosophy, I can't even say that it was really like something that was written down. It was just something I believed and evolved over time, and I'm inducing all these women. And I know that Google and the literature says don't induce VBACs. It says don't induce them because you will end up with a C-section. And I did not believe that because I knew it was not true. If I induce them, I will avoid a C-section. So I was kind of a lone voice in the wilderness, a lone insane voice in the wilderness. A lone wolf. Right. So Kristin could have shown me a lot of medical literature that said I was wrong. And I would have had, and I would have said, well, I don't know where this medical literature is coming from. I am telling you, everything that I have done in my career is telling me I am right, and this is the way to avoid C-sections, and I know that my numbers are right, and I feel the truth, and I cannot accept what you're telling me. But luckily, eventually, the literature came around. Yeah, and I think the other thing about research in general is a lot of times the people who are doing research are not practicing, which is why you kind of need the theory and the experience. You can't just have one or the other. It's a good point. It really is. That's a very nice point. The attributes that make for a good researcher very often don't translate into somebody who's in the trenches in labor and delivery and vice versa. Yeah, which is why often, usually providers are ahead of the literature. So, okay, let's encapsulate this. Yeah, so induction is good. Induction is good, but let me, and I want the audience to verify this with their own little research on Google. Until 2010, every single publication that compared induction to natural labor, spontaneous labor, all said that patients that get induced have a higher chance of having a C-section. And after 2010, every study that was done, no matter if it was in the United States or Britain or France, or if they're 39 weeks, at 40 weeks, older women, younger women, cervix was, ripe, the cervix wasn't ripe. Every study said that if you induce patients, you have a lower chance of C-section. So what happened in 2010? Did humanity just change all of a sudden? Did the biology change? What happened in 2010 that all the literature all of a sudden did a 180 on the results? Well, I think part of it, which I don't think we've talked about yet either, is that it was big data analysis. So they were able to aggregate data from all these studies and put them together and then look at different variables. No, that wasn't it. Although it might have been part of it. But the same studies, they just used a different control group. Exactly, because they aggregated the data. No, they did the studies again. But okay, so in 2010, somebody really smart said, 1 second, why are we comparing women that have gone into labor on their own spontaneously with women that get induced? The opposite of being induced is not being induced, not going into labor. You can't tell women go into labor. So if you want to do a study and you really want to see the effect of induction on C-section, take 1,000 women at 39 weeks and induce them, and take 1,000 women, the control group, a similar aged demographic risk group, and then don't induce those 1,000 women, and then compare who does better. Not right. So what they did historically before that was they said, let's look at 1,000 women that went into labor at 39 weeks, and let's look at 1,000 women that were induced at 39 weeks and see who did better as far as C-sections. And that is an unfair study. When you do a fair study and look at the women that are 39 weeks that are put into labor versus the women who are just left alone. Left alone means that maybe they'll be induced the next day or in a week from now. Maybe they won't. But just regular medical care versus automatically inducing everybody at 39 weeks. The study was done over and over again, and it always showed the same thing. The induced group had a lower C-section rate.
Yes, and then we had the ARRIVE trials, and then we had it replicated many times.
Exactly. The ARRIVE trials show that, and this is all big data, and every midwife, it's really funny because I try to find all the quotes from midwives and all the naturists who hate induction.
Yeah, all my
And
teachers.
they're just so twisted, they don't know what to say because, it's like, oh no, this can't be true. It goes against everything I ever believed my whole life.
But see, in 2010 when I joined you, I wasn't wrong for thinking that induction was bad. And you were ahead of your time.
The data was, by the way, nobody actually, it would have been nice if ACOG or the president of the American Association, somebody would call me, hey, Yaakov, sorry about that. Sorry that we thought you were crazy. It turns out you're not crazy.
Yeah, you're just like Nikola Tesla. Everyone thought he was crazy. And look what happened to him.
But he actually was crazy. I mean, he was a genius, but he was kind of crazy.
Right. So maybe that's true for you too. There's a little bit of crazy and genius in you.
Yeah, he also died broke. I'm going to go with...
And he was in love with a pigeon.
Was he?
Yeah.
Okay,
yeah.
You're not making him sound more sane, by the way.
But he was a genius. Maybe that's like the level of genius you have and the level of crazy you have.
So, this is something you can Google. Compare look at all the recent studies in the last 10 years comparing induction to non-induction at 39 weeks, at 40 weeks, at 41 weeks with different women from different parts of the world, and the study always shows the same thing.
And we'll put in the show notes, we can put the ARRIVE trial and we can put the study that went into the New England Journal of Medicine in 2018.
All right, but today everybody has Google. They can find it faster than...
I know, but they want our help. Let's help them out.
So, if I were to summarize, the best way to avoid a C-section is to go into labor on your own, followed by being induced, followed by being left alone, and
having a small baby.
And having the baby getting bigger, and the placenta getting older, and the baby getting out of position, and preeclampsia developing. And a lot of bad things happen when you leave people alone.
Right. But that's one thing we didn't talk about also is the placenta aging. So it goes through...
So that's a whole different problem after 40 weeks. I would love for every patient to just go into labor at 39 weeks. That would be ideal. If I could just, wish people into labor, I would wish all my patients into labor at 39 weeks.
And you know my theory about that. I think women do that. And it's the women who exercise. It's the runners and the spinners who are exercising an hour every day, 6 days a week. Those women go into labor spontaneously on their own, 39 weeks, 38 weeks, all the time.
Okay, I want to cover one more aspect of this. Even if babies weren't bigger, let's take that out of the equation. Let's say babies were the same size they used to be, and labors weren't any longer or harder than they were before. There's still reason to induce patients because we have zero tolerance for unhealthy children.
Yes, nothing good happens after 40 weeks.
Right. No, I'm saying if a baby is compromised during labor, not enough oxygen, baby's cerebral palsy, any one of those terrible outcomes, right? That's unacceptable. Somebody's going to be, in court and in deposition. There's going to be a lawsuit and some kind of settlement, right? That is not acceptable. In today's society, babies are not allowed to be injured during the labor process, and therefore doctors have to do C-sections because, you can't have a bad outcome. And sometimes it's very hard to predict who's really going to be a bad outcome. So you have to have a bunch of C-sections to avoid that one bad outcome that might happen. So because of that, that's also another reason to induce. Meaning, if we accepted 1% of babies would have cerebral palsy, so then,
And you say when we accepted, you mean like we as a community, as a society?
Right. If that was something that was acceptable, which, is obviously a scary thought, then doctors wouldn't have to be overly cautious when they labor. Labors can go on. Heart rates could be bad.
Right. So there's like a little bit of medical cautiousness.
Right. So, and historically, right, nature, if someone says, nature is 1% of babies didn't come out very healthy.
And I think women don't really like to hear that because women don't want to think that their doctor is practicing that way.
Oh, I hope not. I hope no doctor is practicing that way. But I'm saying when people talk about having a natural labor, they're excluding that whole possibility of having a naturally unhealthy child, which happened a lot in nature. So what I would say is, yes, if you want to have a 100% healthy baby rate, which is what everybody should only aspire to, then you have to do C-sections more often. And maybe a way to drop your C-section rate is inducing. So even if you're going to say to me that babies aren't bigger and inducing is unnatural, so is having babies, having 100% healthy baby rate. That's unnatural. But if that's what you're aspiring to, then you have to be willing to get the babies out when they fit better.
Yeah,
I know that's a really hard to wrap around. Maybe do two wrongs make a right type of thing. But actually, if you think about it, it makes sense.
No, it's a good point, and it's important for this topic. We got a lot about induction and why it's not so bad and why it gets a bad rap when it shouldn't. And
yes.
It is your friend and not your foe.
Induction is
a useful tool.
It is. That's what it is. It's a tool, and along with everything, it has to be used correctly and it has to be weighed with where the cervix is at, how big is the baby, what's the woman's history, how many previous C-sections, or did she have previous normal deliveries, what were the hang-ups, why did she have a C-section, what's the story, what are her desires for the future, how many children does she want to have.
And I think what you're talking about there is that what you're talking about is not so much the science of medicine and what we do, but it's the art of what we do. And just as well as I do, when I see a woman come into the office, intuitively in some way, that's the art of labor and delivery, that's the art of obstetrics, how to counsel this woman what's going to be best for her.
Right. So I think the best analogy, the one I use is a hand of poker. First of all, you really shouldn't know what you're doing or how to bet until you get all your cards, right? And then once you have all your cards, then you actually see what hand you're dealt, because you don't have that much control. A lot of, what's going to happen is going to happen. Is the cervix going to be open? Is the baby going to be in the right position? What's the baby size going to be? When you look at all the cards, some of them are turned up from the beginning of pregnancy and some of that not till the end. Then you play the hand you're dealt.
Right. And we all want to have our cards stacked in our favor, and we all want to be dealt a hand of 4 aces, but it doesn't always happen that way. Sometimes you get a 2, a 4, and a 6, and a 10. And what are you going to make with that?
I go all in. Because, I bluff.
Because you would.
Well, first of all, I have attention deficit disorder. So whenever I play No Limit Hold'em,
it's boring.
I'm out in about 3 hands. Because it's not that. I just, it's so boring. And then I'm like, I'm all in. And then people are like, oh, he probably has nothing.
He's bored.
I'm going to take his money.
And then they do. So then you go back to the craps table.
Pretty much.
So if you like this podcast and you want to hear more, please subscribe. And you can find us wherever you listen to your podcasts. You can also find us on our website at maternalresources.org or integrativeobstetrics.com, and send us a DM, and we'd love to hear from you.